Hi everyone, my name is Morgan Lloyd. I am currently a nurse in the ICU. This presentation for IPC 401, Research in Healthcare, will pertain to the population of critical care patients due to the fact that that's the population of individuals that I work with on a daily basis. The main reason for choosing the topic of noise and sleep is the fact that the ICU has had an increased interest in delirium and its long and short-term effects on patients. There is already implementations of a new protocol to decrease sedation and increase mobility in patients in the ICU to help decrease delirium. As a night shift nurse and seeing a lot of the patients who are awake all night and then again throughout the day. Some of the facts that were found: 50% of sleep in critically ill patients occur during the day, which means that the sleep the patients are getting is most likely from the first phase of the REM sleep, which is not conductive of deep sleep and memory restoration. According to Pisani et al., after someone experiences 30 hours of sleep deprivation, a person's body starts to have physiological effects, such as hormone level changes, impaired immune system, putting patients at increased risk for infection. A person's hemodynamics can be impaired from neuroendocrine control centers being sluggish. And lastly, there's a decrease in muscle endurance, more specifically your pulmonary muscles that help you take your inspirations with each breath. It's also said when someone experiences 1 day of delirium while in the hospital, their mortality rate increases by 10%. So if doing the math, 10 days of delirium and a patient is likely not going to make it out of the hospital. When thinking of what nursing could have some control over in regards to patients and their experience with sleep, noise was thought of right away. Within each unit of the hospital, but especially in the ICU, there are constant noises and beeps from telemetry monitors and vital sign monitors. The ICU is a unit for the sickest patients of the hospital, which means there is a constant movement of patients being admitted and patients being transferred to regular rooms throughout all hours of the day and night. The ICU is always alerted of rapid changing situations on other units and patients who are coding. These are all situations that have loud beeping and bells ringing throughout the ICU. Of course, with the higher acuity of patients, there is more nurses and other staff that cause for increased noise with conversations in the hallways and at the nurses' station. All of these things create noise, which leads to decreased ability for the patients to be able to sleep. The purpose of this presentation is to better understand the impact of noise on sleep and if a reduction of noise and increased amount of sleep have any impact on delirium in critical care patients. The official PICO question is, does the implementation of noise reduction help prevent delirium in patients in the intensive care unit? For P, the population that's going to be focused on is patients 18 or older that are admitted to the ICU, meaning that they are critically ill patients. The implementation that is going to be looked at is noise reduction techniques, compared to the baseline of no noise reduction techniques at all. And if the implementation has any effect on the patient's outcome of delirium. When searching for articles throughout the past 5 weeks, multiple different databases were used, including PubMed, CINAHL, and Google Scholar. All of these databases allowed for a refined search for specific years, peer-reviewed, and allowed to get the full PDF version of the article without having to pay for it. The same keywords were used throughout all of the databases. Noise, along with ICU psychosis, ICU psychosis was used as a substitute for delirium as a suggestion from CINAHL Advanced Search. After using the keywords to search for the articles, the titles of each article were read and examined. This was a quick way to eliminate articles that would not be useful or pertain to the PICO question. After selection of articles was made, each abstract was read, evaluated further to assess if the article was fitting of each of the week's different requirements, and also pertained to the PICO question. The most interesting articles to the reader that met all of the requirements were chosen for each week. Throughout the research project, many emotions were felt. At the beginning, it was exciting and fun to be able to look through all of the different articles and studies that were out there that could potentially help with my PICO question. The first week of searches was definitely the easiest because there were many options of articles to choose from. As the weeks went on and the article types that we were looking for became more specific, there was increased frustrations and with articles that you thought looked like were good articles, but then were not. What I found to be the most frustrating was that some great articles that I was excited about, but they were 6 years old instead of 5 years old because one day I forgot to refine the search for the years that I wanted. Now's when we look at the different articles and see what the similarities that were found between the 5 articles. 4 out of 5 of the articles reviewed were quantitative studies, and all of the studies samples were obtained by convenient sampling. 2 of the quantitative studies by Garcia, Madil, Lesk, and Giron, John, Miskell, Lanko, Wall, and Scalon implemented noise reduction techniques of quiet times in the ICU, where there would be no visitation, the lights would be turned down, less rounding by providers, and there would be less transfers out of the unit. Both studies had success with bringing the noise decibels down and an increase in sleep reported by the patients. There was overall a decrease in delirium rate in both studies, but it was not large enough difference between the two to say for certain that the quiet time was the thing that made the difference at that moment. There was a large increase in patient satisfaction and staff satisfactions in both of these studies. The second 2 quantitative studies was by Drome, Esleviers, Fromont, Journes, and Rampase, and then Demal et al. These implemented noise reduction techniques of earplugs. The findings in each study were different, so we will review the results on that on the next slide. The comparison of differences between the 5 different articles are as followed. The article by Bridges was the only literature synthesis that included 29 different studies at different hospitals throughout the US, measuring noise in decibels. The article did show that the major noisemakers in the hospital were the conversations between healthcare team and the care activities themselves. The study by Demal et al. Included the intervention of earplugs and eye masks. There was less tolerance with both intervention of eye masks and earplugs due to the fact that 9 individuals in the intervention group did not tolerate the intervention at all. In comparison to the study by Drome, which was the study completed with earplugs only 2 individuals from the intervention group were unable to tolerate the intervention throughout the entire study. The study by Demal et al. Was also less successful than Drome. Demal et al. Concluded that the eye mask and earplugs did not make a significant difference in sleep or delirium reported by the patients, but in the study completed by Drome, there was a significant improvement in sleep and in delirium in the patients in the intervention group. There were also different measurement tools used between the studies. Bridges used a decibel meter to measure sound throughout the study. Giron, John, Meskel, Lenko, Wall, and Scanlon used a Richards-Campbell sleep questionnaire to measure the sleep of patients. DeMol et al. Used a polysomnography to record brain waves for measurement of sleep in their study. And then lastly, Garcia, Medill, Lusk used the CAM confusion and agitation assessment scale in their study. As a reflection, the largest source of noise was found to be the nurses themselves. Quiet time intervention showed to be more successful than the earplug interventions for sleep and confusion. And then earplugs and eye masks as an intervention together was completely unsuccessful. The biggest takeaway from the slide, the largest source of noise is produced by nurses and the healthcare team. The biggest thing hurting the patient's ability to sleep is the staff members themselves. Based off the 5 articles reviewed, there's not enough evidence to make a practice recommendation. There were 2 studies that implemented the use of quiet time, but only one of the studies had significant enough decrease in delirium and increase in sleep. There were 2 articles that implemented the use of earplugs, but one of the studies also implemented eye masks. So the 2 interventions were not well tolerated by the sample at all. Due to the lack of consistency, there's not going to be a practice change recommendation. With the literature synthesis showing us that nurses are one of the main causes of noise and sleep disturbances, this provides a huge opportunity for nurses to be able to change the level of their voices, the volume of the monitors, and clustering care as much as possible to be able to help the patients get better sleep to help decrease the risk of delirium. Since there continues to be a gap in literature for what noise reduction techniques could help the critically ill patients with gaining sleep, there's opportunities for others to continue the research to help understand what could help this population gain sleep. Thank you for listening. This concludes my literature review presentation. This is the reference page for the articles used, followed by the references for the photos throughout the presentation.